So the next session is going to be more focused on looking at living donation in more detail. And first, Lisa King is a living donor evaluation here at Mayo, and she's going to start this part of the session.
Thank you. Good afternoon. So today we're going to talk about a living donation. So, oops, not going. My bad. No, that's okay. Thank you. So the objections that I'd like to go over today is the actual living donor process. I'd like to go over some of the criteria for who can be a living donor. I will touch briefly on our kidney paired program, and then I want you to consider factors for consideration. So to start the process, the donors here typically have to have a recipient that's already listed and ready for transplantation. Those recipients will go and talk to someone they know, a loved one, a family member, and ask them if they would be consider being a donor for them. If so, then the next step in the process would be at our center for them to go on an online form, which is called Breeze, and they fill out a questionnaire. Now, if they do not have access to internet, they can certainly give us a call at our toll-free number, and we'll do a phone screen over the telephone. So this online form at our center, you go into mayoclinic.org/living-donor, and then you would select that you want to be or fill out the questionnaire. The questionnaire that we ask the donors to fill out takes about 15 to 20 minutes to fill out. It is completely confidential. The only people who have access to the living donor form are the 3 RN coordinators, our social workers, and our administrative secretary. So it is very confidential. The recipients don't have any idea who's filled out this form or what information is there. We do ask that the donors answer these questions truthfully and accurately, because that gives us a good idea or a good indication of whether medically and psychosocially these patients would be a good fit to be a donor. They also have to figure out if they want to be a kidney donor or a liver donor, so it's good if they know the recipient and what organ they're being transplanted for, because that's part of the form. And then the form, since it's a 3-site form, they also have to select where the recipient is listed at, either Rochester Mayo Clinic, Arizona, or Florida. And it's amazing how many times people hit the wrong button, so then we have to reorganize things. Now, there's also a place in this form that if they don't have a recipient and they would like to be an altruistic or a non-directed donor, they can also list that on the form, and then that's a different process for living donors. To be an altruistic donor, you should be probably 25 years of age, which is a little different criteria than what our normal donors would be. So once that form is filled out, they hit the submit button, and then one of the 3 RN coordinators will call them. We'll review that medical form with them. We'll go over the process. We'll answer their questions, and away we go. So some of the criteria for most donors, we ask that they are between the ages of 18 and 70. Greater than 70, we have accepted donors, but then it's by a case-by-case situation, so we want to make sure that they're healthy. We do look at their body mass index, or their BMI, and each center has different criteria. Here, some of the criteria that we like is if the donor is less than 31 years old, they should have a BMI of less than 31. If they're 40 or over, if their BMI is less than 40, we would accept them. So our criteria is a little bit different than some places. We also will look at their glucose. If they know what their fasting glucose is, or if they've had labs, we'll ask what those are. And again, you know, from the time we're born until the time we're not on Earth anymore, we're not the same, okay? So our organs don't work the same, our labs aren't the same. So it's really important that we know this going into it, because maybe a 60-year-old donor that's taken ibuprofen all their life is not going to have a very good GFR. At the same rate, a 30-year-old that takes ibuprofen every day, maybe it's not going to have the best GFR for them to go forward to be a donor. So all very significant things. We also ask them about their blood pressure. Of course, if somebody is 25 years old and they tell me that mom and dad both started on blood pressure medications at age 40, maybe this isn't the right thing for you to do to be a donor. So it's really important to dig into that family history a little bit. And then, of course, there's a lot of psychosocial things because these are supposed to be well people, and sometimes we find out they're not as well as they think they are. So it's really important to ask those questions during the screening process. Now, if the donor calls and we know that their recipient has polycystic disease, that's not an automatic rule out. Please keep in mind that 50% of any family member who has a recipient that has polycystic disease may have the same disease themselves. So there's a 50% chance of that. So before we're going to bring somebody here for a donor evaluation, we are going to do an ultrasound, and this should be done locally. Now, if there are more than 2 cysts in each kidney and the donor is greater than age 30, then we would consider them positive for having PKD themselves. If the ultrasound or CT is negative and they're over age 30, they can move forward to be evaluated. Now, if the ultrasound is negative and they're younger than 30, we might move to get an additional testing with an MR or a CT, and then we would also send a consult through to our PKD specialist, Dr. Torres, to ask him what his opinion is and let him see what the CT and MR would look like. After those results, that donor would either be accepted or denied. If they're accepted to move forward in any donor case, the first thing we do is send them a kit for them to do some blood work locally. That blood work would include getting a blood type because, of course, we want to make sure they have blood type compatibility. We also look at class 1 and class 2 antigens. So we're always looking for that 6 out of 6 match. However, we know that doesn't happen very often unless it's an identical twin or possibly a sibling. So, anybody that, even if you're a 0 mismatch, could still come in and be a potential donor. Depending upon the recipient's CMV or EBV status, we also might screen that before we would invite a donor to come. And then if donors are over age 60, many times we're also going to ask for a fasting glucose, a creatinine, and we may ask them to do a 24-hour urine creatinine clearance to make sure that their GFR is okay to move forward. We should have those results back within 3 business days after the donors have the labs taken, and then we ask that the donors contact us. Many times they forget, so we will contact them and let them know if their blood type and their HLA is acceptable for them to come forward, and if so, then we schedule the donor evaluation. That typically takes 3 days. It has to be done Monday through Friday, of course. It includes a variety of appointments. We have a multidisciplinary team that we work with. This isn't just a surgeon, a nephrologist, or coordinators say it's okay for them to come forward. Everything is completely separate from the recipient. So the donor team goes down one path while the recipient team goes down another path, and we actually don't meet until we actually get to the day of transplant. Everything is confidential. So if a recipient would call and say, who is coming, where are things at, I don't want that donor to come, we don't tell them. So I also want our donors to know that this is never a signed and sealed contract. So anytime along the way, a donor can elect to stop the process, and that's perfectly acceptable. At the same time, if the team finds something that we think will place them at higher risk, we can stop that process. And again, it's always confidential. So the multidisciplinary team that our donors typically would see would be our kidney doctor or the nephrologist, our surgeons, the independent living donor advocate, our social worker, the RN care coordinator. They're also going to see a blood pressure nurse after they wear their 18-hour blood pressure monitor, which most of our donors tell us is the worst thing we put them through. And they will meet with Transplant Financial. They also may meet with a transplant pharmacist or a dietitian, depending upon if they meet criteria or where that criteria falls, but they will all have a consult, at least with a pharmacist and a nutritionist. Many, many blood tests are taken. We test for just about everything imaginable. Most of our donors tell us they draw about 18 tubes of blood before it's all done. We're going to make sure that they're heart healthy. If they're over age 60 or if they're a smoker, they're going to have an echo. They all will have a CT scan. We want to make sure we know what their anatomy is, make sure that there's no cysts or stones or something funny that we find in their CT scan. We'll do cancer screening, which would include if they need a mammogram, if they need to have a colonoscopy, if they need a pap smear, they can get that done while they're at our center as well. If for some reason we find out that the recipient and the donor are not compatible, so maybe a cross-match comes back positive, or if they're an EBV or CMV mismatch and it would behoove their recipient to get a negative donor, then we talk about our paired program. Now, the paired program means that the donor would donate to someone they didn't know in order for the recipient to get a transplant from someone they didn't know. So basically what we do is just an exchange, or we just interchange donors, okay? So this chain can be anywhere from 2 pair to up to 8 or 9. If there would start with a non-directed donor, then that chain can go on for quite a while, okay? So we look at blood compatibility, look at the antibodies. If grandma wants to donate to her 25-year-old grandson, perhaps it would best for the 25-year-old grandson to get someone closer to his age. So that's something, too, when paired could be considered. So once that match is found or a chain is identified, then we would send kits to do another cross-match with the new donor, new recipient pair. If that cross-match would come back negative, then we get other information. So if this person is coming from somewhere outside of our own facility, we want to look at their CT, we want to look at all the notes, make sure that this is a good donor for us. If everything is all right, we can start to look for a surgical date. Please keep in mind that a kidney can certainly be shipped outside of the facility that we work with, okay? So it might not stay at your center. So the recipient will get that kidney transplant. It's a definite benefit. The kidneys from live donors, we know, last longer, and they usually need fewer immunosuppression medications, and we always hope to get our recipients off of dialysis as soon as we can. Some of the things with the paired donation that people have to keep in mind is they need to be flexible. Okay, so once we get these cross matches, we can set a surgical date usually within a couple of weeks. So that means, do you have your caregiver ready to go? Are you okay with getting off of work? Do you have people to take care of your kids at home? The other things that you have to remember is when they come back the day before the surgery, things can happen. You know, if suddenly labs aren't good in one person in a potential chain, it can be postponed or actually canceled. Or in the case a couple of years ago, we had a big chain that was going to start with their surgeries on a Thursday, and the weather person told us on Monday we were going to be getting a big storm, and we were flying an organ in from Arizona. So that was like, how often are weathermen right? You know, we ended up canceling or postponing that. So they have to be very flexible. So it's really important to talk to our donors about that up front. So again, the advantages of getting a living donor, shorter waiting time, hoping to either avoid dialysis or get patients off of dialysis. Of course, it's a better and planned surgery, and the outcomes are much better. The cost of the evaluation for donors all go onto the recipient's insurance. So there's some exceptions to that. So if something happens during the donor evaluation that we need to look at other medical things, that could go onto their insurance. Okay, so if it's not donor related, some costs could be incurred during the evaluation. The expenses for the donors include their travel, their lodging, time away from work, if they've got day care expenses. It's very important for donors to realize it is illegal in the United States for donors to be paid. Recipients' families can help them with expenses, but we don't want to find out that somebody got $10,000 to be a donor. So if the donors decide after they've been here for their evaluation that they don't want to do this, or there's something that comes up in their life that tells them that they can't do this, the evaluation would stop. Again, everything is kept confidential, and the recipient does always have other options. When the evaluation is completed, it's not up to just the people who have seen those people that day to make the decision of whether or not they're accepted to be a donor. We have a multidisciplinary selection meeting that all of the information for all of our donors are taken after they've completed all their testing. And at that time, we give them the thumbs up, everything is okay, or we say, oh, well, we got to wait a little bit, you got to work on a little bit of weight loss, you know, you weighed a little bit more than you thought you did when, you know, we did the phone screen. Or we say absolutely not, you know, if there's some sort of anatomy issue that's not right, if there's a psychosocial issue that came out during the evaluation, then they could be denied. If they're approved, the evaluation is good for up to 18 months, and then we set a surgical date. We ask that the donors return the business day before the surgery, and that's when they had their surgical listing and have their pre-anesthesia medical evaluation. They are admitted to the hospital the day of the surgery, and we tell our donors that they're going to be in the hospital about 2 nights. And we do offer them a visit in the clinic once they're out of the hospital. So in the donor, it is a hand lap, so they'll have a 3 to 5 inch incision and then 2 1-inch incisions in either the right side or the left side, depending upon what kidney we use. The total donor surgery takes up to 3 hours. To get that kidney out, probably about 20 minutes. As of anything, there are risks anytime anybody has surgery. Blood loss is, they maybe lose 1 to 2 teaspoons of blood throughout this process. It's very rare that they would need a blood transfusion, but it could happen. There have been rare instances where that 3 to 5 inch incision for the hand lap needs to be reconverted and made into a bigger incision because of possible complications. You can always get an infection. Sometimes anesthesia can make you nauseous and make you not feel very good afterwards. But most donors don't have any long-term implications whatsoever. In the rare case that a donor would have kidney failure and they would need to have a transplant themselves, there is a policy that UNOS has that says that if they meet criteria to get a transplant, they would get extra points that would either put them on the top of the list for their blood group or be close to the top of the list for their blood group. And of course, they always have the option of having a living donor come forward as well. After the surgery, it's important for them to know that they're going to be tired. There's going to be fatigue. Most of our donors tell us that the fatigue lasts maybe longer than anything, maybe up to 6 to 8 weeks. They're tired. They get back to work within 2 to 4 weeks, sometimes 6 weeks, depending upon what they do. But, if they go back to work at 2 weeks, they're going to tell me by Friday night they're tired and they are ready to rest a little bit. And that does get better, but it's very hard for these well people to know that they're going to be unwell for a short period of time. As far as activity restrictions, we do ask our donors that they don't lift any more than 10 pounds for about 4 weeks. 10 pounds is about 1.5 gallons of milk. That's not very much. It's probably my purse. It's a vacuum cleaner. It's shoveling snow. So it's very important that you give them some common things that it takes that doesn't take very long. And then we do ask our donors to avoid getting pregnant for the first year after surgery. They do stay in near our facility for 2 to 3 days following the surgery. If they want that appointment once they get out of the hospital, we're happy to see them. There are some regulatory follow-up that we need to follow up. So we ask that our donors return to see us for a 1.5-day evaluation anytime after 4 months and before 8 months. And then we also send them blood kits at 1 year and 2 years. At that time, the regulatory regulations are all completed. However, if somebody is 5 years out, if they're 10 years out, I don't care. I want them to call and let us know. I may not be here 10 years from now, but the program's not going away. So I want them to call and let them know that they are always welcome to call us with questions or concerns. So of course, long-term considerations is, is it okay to be away from work? Is it okay to come to Rochester not once for evaluation, but twice? So you're going to come for the evaluation, then you're going to come for the surgery. So travel time, are finances okay with that? Do you have daycare issues that you need to worry about? Do you have a caregiver? For a husband and wife team, you need 2 caregivers because the spouse can't take care of the spouse, because they're both going to be recovering from surgery. It's important for our donors to realize that this does not decrease their life expectancy. There are no dietary restrictions. However, we should all watch our salt intake and our fat intake, and as Americans as a whole, we're not very healthy with doing that very often. It's also very important that they watch their NSAID use afterwards. So if a person before transplant is using NSAIDs or Motrin or Aleve every day, that's really something that they need to consider. Do you really need that, or can we stop doing that? Because it can definitely affect your long-term kidney health. It's also going to be important that they drink 6 to 8 glasses of fluid a day, and half of that should be from water. And I always tell our donors to keep in mind that alcohol and caffeinated products dehydrate you. So we all get dehydrated sometimes, but if you ever have caffeinated products, if you have a beer or a wine cooler, it's okay. Just drink more water because I want that kidney to be nice and plump and happy. So there really are no general activity kind of no-nos. I don't know if I'd want them to go back and play professional football or hockey again, because I would want to be careful about that. But So that I want them to take in consideration their health, their employment, their recovery. It's going to take time. You're going to have surgery. You're going to be unwell for a short period of time. It's something that you got to keep in mind. And then to follow those post-surgery recommendations. A lot of us, if we feel good, we don't go to the doctor every year. It's really important for them to have annual checkups with their local provider, because I don't expect them to come back to the center that they donated at, but I do want them to have long-term follow-up and establish a local provider. There's some different websites that you can go on for any questions. UNOS has great websites. Transplant Living is all about living donors, and the Kidney Foundation. So, and with that, thank you.
We're going to head with the second part of this living donation tag team. Now Margot Van Drovic is going to talk. She's an independent living donor advocate here in the transplant program.
Thank you for giving me this opportunity to speak to you today, and I'm excited to tell you about the donors and how interfacing with them in the role of the donor advocate is a very rewarding position to have here at Mayo Clinic. So what I wanted to go over today is what is the role of the donor advocate and the responsibilities it entails, the process involved when a donor comes to the Mayo Clinic Transplant Center, and where a person can find more information. I'm also going to flip on a hat today of the living donor social worker, because my colleague was not able to be here today, but she has some important information she shares with donors and what her role and responsibilities are, and the financial considerations for donors. How does a person find a living donor if they don't have one in their particular family? And what do donors really think about donating? All transplant centers in the United States are required to have an independent living donor advocate or a living donor team. That can look different from transplant center to center. Some of the donor advocates have a dual role, both as a social worker and the donor advocate. At Mayo Clinic in Rochester, it is a separate role. I happen to be a social worker. In our other two sites in Arizona and Florida, those donor advocates are chaplains. Other donor advocates that I'm aware of have been nurses, ethicists. There's a nephrologist in one center in the United States. So there is some variability there. Living donation is completely voluntary, so protection of the donor's health and safety must be ensured. And the donor advocate's sole job is to look after the interests of the donor. The teams are separate. You heard the recipient team with Aaron and Tammy talking. The donors have separate teams as well. This is a voluntary thing, and not everyone is completely convinced that they want to do this or know a lot about it to make a decision. So we have to ensure their confidentiality, just as the recipient's confidentiality is also protected. The donor advocate represents and educates the donor about the process, protects and promotes the interests of the donor if they want to go forward, to let the team know that, to respect their decision and ensure that their decision to come forward is informed and free from pressure by anyone. The donor advocate stays with that donor. We sort of stick with them like glue through the whole consent process, the evaluation process, their hospitalization and afterwards, and their follow-up that Lisa had mentioned at 6 months, 12 months, and 24 months. This can take the form of phone calls, corresponding with them, and face-to-face visits. We just don't want the donor to ever think that we've forgotten about them and about the donation that they've given. So it's important that the donor understands this whole process. So as a donor advocate, I go over these, the consent and the evaluation and the surgical procedure. I like to say that I sort of water ski over that part and let the medical team go into more of a deep dive, which Dr. Dean will do later. And the medical and psychosocial importance, including the financial risks. And Are they ready and able to commit to ongoing post-donation follow-up? Deciding to become a kidney donor takes time and careful consideration. And we need to be assured as a team and as a donor advocate that they have all the appropriate and adequate information to understanding the risks of the surgery and the benefits and the outcomes, not only to them as the donor, but also to the recipient. And adhering to the legal prohibitions against accepting payment for their kidney or any financial profit. We think it's important that the donor have some understanding of the recipient's situation because it just improves their overall understanding of transplant and the donation process. And donors have the right to stop the process at any time or to slow it down or reconsider at a later date, and their confidentiality regarding this is protected. What's involved with the evaluation process? As Lisa mentioned, you'll be meeting with individuals on your donor team. And at the Mayo Clinic, that is done appointment by appointment. At some other transplant centers, they do this in sort of a round-robin fashion. So you meet with a nephrologist or the kidney doctor, the surgeon, a donor advocate, and a donor social worker. If needed, with one of our psychiatrists. You'll meet with the donor coordinators and the transplant center financial coordinator. Their role is to make sure that you understand the evaluation, the surgery, and the follow-up, and if there are complications related to the surgery, are billed to the recipient's insurance. We have pharmacists and dietitians on staff, as well as any other specialists that may be needed in that evaluation process. It includes the full physical examination, including the testing, and as mentioned, we do this in about 2 to 3 days. It's a pretty rigorous process, and I've referred to it as donor boot camp, but it does keep people engaged in the whole process and keeps you from missing a whole lot of work if you can concentrate on getting here to the Mayo Clinic in those 3 days. We do a full psychosocial evaluation, including a financial assessment. It's very important for us to know that this donation will not create any lasting financial hardship for the donor. And determining that your kidneys are healthy enough that you can donate one, and that the one you keep will hold you in good stead for decades to come. The laparoscopic surgery technique is what we use here at Mayo Clinic, and it lasts a few hours. You're in the hospital 2 to 3 days, and you're able to discharge home after the hospital if you live nearby, or in a hotel if you are coming far from home. The medical risks are pretty universal with any operation. They may include infection or bleeding, blood clots or fatigue. Rare complications can be included, such as a heart attack or stroke or death. And these are extremely rare, but the donor has a right to know they're a possibility and must be taken into consideration. And the rare but possible need for a kidney transplant in the future if the remaining kidney were injured or something happened to it in years to come. The financial risks are the personal expense of travel, meals, lodging, and child care. Some of these expenses may be covered by the recipient's insurance, but donors don't often know that. So if the recipient does a little bit of homework with their insurance company beforehand, that would be very helpful for a donor. Lost income from for the donor and possibly the caregiver when they come for the surgery needs to be looked at as well. The use of sick time and vacation time, the impact on your health insurance, life insurance, and disability insurance. And because there are so many different plans and companies out there, if you have questions, we ask you to check with your insurance company to make sure that it would not be impacted. Currently, it is protected under the Affordable Health Care Act that living donation cannot be seen as a pre-existing condition for an insurance company, and that's a very helpful thing. And it's also important to consider your lifelong medical follow-up, which would be done after those 2 years at your own expense. Some of the psychosocial risks are the possible problems with body image, thinking of yourself differently after the surgery, and maybe not liking the way the scar heals, the possibility of depression or anxiety after surgery, the feelings of emotional pain if the recipient doesn't do well, temporary changes to your lifestyle, and the impact on your family. You might be very excited going forward as a donor, but your family might be more nervous than excited, and it's important to talk and work through those things. Why is follow-up important after donation? To assess the ongoing well-being of your entire body and including that remaining kidney. So that's why we really find it important for you to come back to the transplant center if at all possible. If there are complications that arise, we can address those and to continue to support you. Another important thing is the results that we collect, we report to the United Network of Organ Sharing, and this is true for every transplant center in the United States. And that's their way of tracking donor outcomes and even developing and changing policies in the future to make sure this stays a very safe option for people. The benefits of living donation are the emotional benefits of increased well-being, a sense of well-being and quality of life, the ability to improve the quality of life for the transplant recipient, and the sense of giving the gift of life to another in need. There are no medical benefits outside of maybe a terrific medical examination, but these emotional benefits are what carry the donors forward and keep our phones ringing for people wanting to do this. For more information, the prime place that I would suggest going to is the United Network of Organ Sharing. They have a wonderful booklet that they put out that explains things for living donation. It takes a little bit of work to find it. You have to hover over a tab that says living donation, and then a whole PDF booklet comes out that is chocked full of information and other links. And you can also find more information under transplantliving.org. Two different places will get you two different websites. The National Kidney Foundation is also an excellent resource, and they have a website called Informate, which is for the Spanish and English-speaking people who would like to know more about donations. I'm going to put on that hat that I talked about called the Living Donor Social Worker. That is a separate role. They also are members of the Living Donor team. They assist the donor team in determining the appropriateness of donation for a candidate. They complete the full psychosocial evaluation. And the same components that Erin Hamilton talked about in her psychosocial evaluation are what the donor social worker includes as well. It's important that we explore a mental health history, including depression or anxiety, counseling, psychiatric hospitalizations in the past, or any history of suicidal thinking or attempts. To assess the chemical use history, including the famous question about marijuana, alcohol use, prescription drug overuse. All these things could impact the donor's future health. And an increased risk behavior form, which again, every transplant center in the United States asks about, and it has to do with the fact that some bloodborne pathogens can be passed to the recipient, and we need to be attentive to those. The social worker assesses the availability of social support for practical and emotional assistance throughout the whole donation process. Lisa touched on that when she talked about having a caregiver. And people think that's kind of funny for a donor. Why would they need one? They need the emotional support during the hospitalization. They need that person to help with carrying and lifting and preparing meals. If they have little ones at home, they can't lift them if they're over 10 pounds. So having excellent support systems throughout the whole continuum of care. The social worker also assists the donor and the family to manage and cope with the donation process pre and post-surgically, and assist with financial assessment and shares available resources that are out there for our donors. The National Living Donor Assistance Center is an excellent resource that can help pay for some of those out-of-pocket expenses, including travel for the donor and their caregiver who comes, not only for the evaluation, but for the surgery and follow-up. They're highly committed to donors, and they try to work within their guidelines. They are federally funded, so some of their recommendations and requirements come from the recipient's earnings, and the website talks about that quite extensively. The American Transplant Foundation has a fund that helps people who do not get paid for their time off work, but income restrictions apply. And the National Kidney Foundation, again, is a wonderful resource of how to navigate through the expenses for donors. The American Society for Transplantation within the last 2 years has put out an excellent resource called the Live Donor Toolkit. It also includes a worksheet of how to write down your expenses and how much to anticipate and plan for when becoming a donor. Throughout the United States, in about 30 states, there are donor leave laws and tax deductions or credits for living donors. And if it's hard to navigate through this site, if you just put in your search bar donor leave laws, you'll find a whole printout that explains how your expenses can be credited in different states, or even paid time off work that is supported by individual states. And there may be other programs, state dependent, or areas that have special programs for financial reimbursement for donors. Resources for finding a donor. We're asked this quite often, and I think maybe Erin Hamilton can speak to this as well as Tammy. There are many pathways to finding a donor, often through word of mouth, through family, friends, or faith communities, health clubs, and volunteer groups. We've heard people sending out letters at Christmas and other holiday events. They've met one another after years at a high school reunion, at college fraternity and sorority groups, alumni associations, and the military, friends through that whole network. And again, just contact a transplant coordinator or social worker, and they may have other ideas for you. We see a lot, and Lisa can attest to this, through social media. A lot of phone calls come forward when people post things on Facebook and other places. And something new that's burgeoning in the United States is something called donor champion programs. It's for recipient families who are looking for a donor champion, someone in their family that can help get the word out. And these are available through a few transplant centers in the U.S. Resources, again, for finding a living donor is the American Transplant Foundation, the Living Donor Connector, National Kidney Foundation, the National Kidney Registry, and the Living Donor Network. I'm often asked, what do people really think about donating? And donors will want to know other people's experience in this, and so do recipients. There sometimes can be some guilt associated with asking people about this, or why would somebody want to do this for me? So I've collected some quotes from donors. If I would have known about living donation, I would have done it 40 years ago. If I had to do it over again, I would do it in a heartbeat. It's a humbling and emotional, positive experience. I just feel excited, not nervous at all. Is that normal? I knew there were risks. I weighed those risks carefully, but rode the wave of positivity. My only regret is I have only 2 kidneys. They test you very thoroughly to make sure you're healthy enough to be able to donate. The great thing is I was healthy, and the other great thing is I was able to donate. It was a no-brainer. I was given a great opportunity to give a kidney, and I did. I felt awesome. You feel like you're giving life. I'm glad I was the one chosen to be the one to help my uncle out. They don't let just anybody do it, but I'm not just anybody. I'm healthy all around, and I'm determined. It's the best thing I've ever done. Thank you. And I'll leave room for questions.
Thank you so much, Lisa. We do have quite a few questions, actually. So we'll start with, we had several questions about living donors and cancer, specifically melanoma. So can a person be a living donor if they have had cancer?
Dr. is going to come up and help us with it. I'm so glad you're here.
Sure. Typically not. The only exception is skin cancers, non-melanoma skin cancers. But typically we don't actually take donors with any form of cancer. even if they're cured, because there's still risk of transmitting something to the recipient, some badness to the recipient, and also to protect the donor health as well. So.
Okay, thank you. Can a living donor live in another country, and will insurance cover a donor from outside the U.S.?
Yeah, we have many donors that are from outside of the country. With our people like from Saudi, they have to go through the embassy and they have to get clearance for payment. In Canada, it's a little bit different because of socialized medicine, so the follow-up and getting those labs can be a little bit more tedious. But yes, we do have donors that come outside the country.
Okay, next question. Does the donor have to be evaluated at the same center as a recipient, or could some tests be done locally if they don't live in the same place?
We would prefer that they come to our center to be evaluated. In the case with Mayo Clinic, since there are clinics in Florida and Arizona, the donors can go to those places to be evaluated, but then it's up to our selection committee to review that information and either approve, defer, or deny. But as far as getting other outside testing done at other facilities, we don't recommend that. Colonoscopies, mammograms, pap smears will take that information. If there's been a donor that's been approved at another transplant center and then that recipient has transferred to our facility, we again will get those outside medical records. We will review them depending upon when those testing were done, and if a CT is available and we can get the films, our surgeons will look at that, and then we will make the determination of what testing would need to be done in addition to what's already been done.
Yeah, typically donors have to donate in the same center the recipient is. The exception is for paired kidney exchange program. What we do is when we get actually a file for a donor who's been accepted another center, we review it as if it's someone who came to us, but they can do their evaluation, of course, in the other center. That's in the case of paired kidney exchange. Now, if we have potential donors who actually live outside the area or cannot come physically to Mayo initially, we may actually ask to do some initial labs, like determination of kidney function, creatinine levels, urine analysis that we can review. But the evaluation is preferably actually, it's mandated to be done locally at the transplant center. Any other questions?
Yes, we have some more questions. Thank you for that. Are the criteria that you listed for donors specific to Mayo? Would other centers have more or less stringent criteria for their donors?
Yeah, typically, most centers share the same. There are different standards in each center, but the basics actually that protect the donor health are the same. I would say they're really standardized. There are parts of the country that request certain testing. People who live in Arizona or wherever, there are certain serologies that we may request that are endemic to such areas, meaning some infections. But typically, I would say it's pretty much standardized. There are minor differences among centers. But the value of the kidney function that's acceptable to donate and such, absence of protein spilling in the urine, and those are pretty much well standardized. There are a few differences here in hypertensive donors. Most centers don't accept hypertensive donors. At Mayo, we have exceptions. We accept hypertensive donors, but they have to have certain stringent criteria, being Caucasian ethnicity, because we know some minorities such as African Americans or Hispanics, they have actually worse blood pressure control. They have to be only on single blood pressure medication. They have to be older than 50 years. But I would say pretty much it's similar across centers. Very well standardized.
Okay, thank you for that. Is there a limit to the number of people that can go through living donor evaluations at the same time?
Yeah. So, we will send out numerous kits to our donors, and then we only ask that one donor be evaluated at a time because the cost does go on to the recipient's insurance. And then at the same time, if we have 6 donors coming for one recipient, then that takes 6 slots that another recipient won't have that same ability to get a donor here. Now, if the donor comes through the process and we find out they need to go into the paired program, then we could go back and look at other donors who have called us to see if we can bring a second one that may be an actual match without being in the paired program. So in that case, we would bring a second donor. Otherwise, we stay with one.
Yeah, that's very specific to Mayo in terms of recipients who are enrolled in the paired exchange program. We can actually sometimes have potential donors, many donors, can be as many as 5, 6 of them. And if we have any, we put them in the exchange program and we run the program. If we see any nibbles, we can actually ask that potential donor to step forward to do the evaluation. But as Lisa said, typically we reserve it to one donor because of cost. But there are potential donors that are put in the back burner, and if we find any potential matching from a different pair, we actually advise them to come to do the evaluation.
Okay.
Other questions?
Yes. So I think we addressed this a little bit a minute ago when we were talking about hypertension, but if a donor is on medications, what medications would be unacceptable? One example that was given is cholesterol medications.
We accept patients with high cholesterol if their cholesterol is well controlled on medication, so that's not an exception. It's not a contraindication to donate. For blood pressure, can be any single blood pressure medication that control the blood pressure. Can be any class of the medication, whether beta blocker, calcium channel blocker, or diuretic. It doesn't matter. It should be one single agent. We have donors who have some psychiatric issues like ADHD. They're well controlled on their meds. They come and step forward to be a donor. We actually approve them if they're well controlled on their psychiatric medication. So that's not a contraindication as well. We exercise caution in terms of people who are on painkillers, especially narcotics and stuff, because the donor surgery may trigger certain, people who have chronic pain. We sometimes people with the chronic pain may not be accepted as potential donor because simply the surgery itself can put them at some risk of having more pain. So this can be an exception. It's case by case, I would say. But cholesterol medications are okay. One blood pressure medication in Caucasian who's 50 and older is fine, and certain psychiatric medications are fine. Other questions?
Yes. So for living donors, how quickly does their kidney function begin to improve after surgery? And can you tell us what % of function a living donor would have immediately after their surgery?
Right. So that's a good question, actually. I discussed that with potential donors. Typically when we do determination of kidney function, whether through injecting a substance, something called iohexol or iothalamate, and we get actually a good estimate of the kidney function. or through creatinine clearance. What happens, the day of surgery, obviously the donor will lose 50% of kidney function because we assume that both kidneys are contributing the same 50% each to the kidney function. The good thing physiologically, what happens is the remaining kidneys start actually to compensate for the work of 2 kidneys. And within about a week to about a month, 4 weeks post-donation, the remaining kidney can actually contribute to about 80% of function of 2 kidneys. So yes, initially they lose half of their kidney function, but the other kidney can compensate up to 80%, depending on the age of the donor. I'm talking about younger donors, they can go up to 80% of function. There is a lot of data in the literature that support that. Other questions?
Thank you. Can you remind us, what is the recovery time for a living donor, and how long does a living donor need to stay in the hospital?
Yeah. Typically, it's 2 nights. I rarely see people stay more than 1 night. 2 nights, an extra night. Typically, some donors, I would not say that, mostly gentlemen more than female, more than ladies, they may have a little bit of more pain, or the bowels do not come back to normal within a couple of days. We may actually extend an extra day. I would say typically 2 days, up to 3 days or 3 nights in the hospital, not more than that. They're extremely rare that we have more than 3 nights.
Thank you.
Other questions?
Yes. What about the age of a living donor? What is too young? What is too old?
Yeah. First of all, the donor has to be 18 and older in order to get the consent. In the situation of an undirected altruistic donor, different institutions have different cutoff. Our cutoff here, at least 21, but preferably 25, so they know what they're getting into. The upper age limit, I would say up to 70 in our center, 70 years. So it's case by case, We have people in their 60s that are healthier than people in their 20s. So up to 70 years, I would say, can be okay to donate.
Okay, thank you for that. So I want to switch now, I think, a few questions about the recipient. Well, this has to do with age too. So if a transplant recipient is approved and they're over the age of 70, would a living donor be considered for them?
Yeah, actually that's the preferred measure, and that's preference here at our center, because technically we know waiting for a deceased donor can be long and lengthy, can be up to 5 years, and certain areas of the countries can be actually longer. So that's actually a program policy here, and it's really enforced when we see the recipients who are older than 70 that their better shot is to get a living donor transplant. Actually, it's recommended because, a 70-year-old or 75-year-old, if they wait another 5 years on dialysis, they will not be as healthy in 5 years, to receive a kidney transplant. So it's a recommendation, and that's preference to have a living donor after the age of 70.
Okay, thank you. If you have a living donor, do you have to wait until your GFR is 20 to be evaluated?
Actually, we can do and if you go to the regulation, the UNOS regulation or regulation, people can have a kidney transplant even if they don't have kidney disease. So there's no, so actually we have people we transplant early on with GFR, close to 20, between 20 to 30. But typically to accrue waiting time, the rule of 20 comes in. But if they have a living donor, I mean, technically, there's no any law that says, you know, we cannot transplant someone who has GFR 24. But what our recommendation is, get out of your kidneys as much as you can. You know, especially in polycystic kidney disease, the good thing about it, most patients, I will not say all patients, they progress really slow, which is a good thing in a way. So I would say they can be transplanted between 20 to 30, but we prefer, you know, to do it when it's actually the GFR is lower. Any other questions?
Yes. So the next one is, how much more beneficial is it to receive a kidney from a younger donor versus an older donor?
Yeah, that's a good question. Actually, if you look at all donor literature, the first and the most important determinant of the longevity of the kidney in the recipient, the longevity of the kidney transplant, is the age of the donor. The younger is the donor, the best is the outcome. The reason is, you know, when we're young, as we age, we lose some of those filtering units. We call them glomeruli. So a younger donor would have more kidney mass and more filters. So, and that actually translates when we actually do the transplant, translates in the recipient. So donor age is the main factor to determine kidney outcomes post-transplant. That's the single most important factor, positive factor, or a younger age. Other questions?
Yeah, so for a patient with a GFR of 20 to 25, what is the protocol for monitoring their status? So for example, do you do routine aneurysm scans? Would you look at their kidney size? Are you concerned about liver cysts? Do you check pancreas? Things like that.
Right, right. So actually, typically we defer that to the treating nephrologist at home. When they come in at 25 or 22, we do, if their own nephrologist did not actually subject them to screening, we help them, you know, do those screening tests for brain aneurysm to rule out. But typically we defer it to the local nephrologist at home to do those screenings. On annual basis, if they're waitlisted, if they have a GFR of 20 and less, now I'm switching to the 20 and less, if they're on the waiting list and they're waiting for a deceased donor, we actually follow how big are the kidneys. If there are people who have kidneys that tends, you know, or cysts that tends to grow faster, we may actually ask them to come on annual basis, meet at least the nephrologist and the surgeon to examine their abdomen to make sure there is room to place a kidney if they are called for transplant. But between, you know, between the 20 and 25 GFR, we typically reserve that to the treating nephrologist, because technically they don't come to the transplant center as often. But when they come for evaluation, we actually subject them to what they need to have. Or we make recommendation to their treating nephrologist. You know, here at Mayo, you know, most of our providers, our nephrologist providers who refer to us internally, they typically, we don't worry about that at transplant specialists, because already most of our patients with PKD have all the necessary testing done. But, you know, it's different in other centers. More questions?
Does Medicare pay for living donor surgery?
Yes, it does.
Okay. So which would have a better outcome, a younger deceased donor or an older living donor?
Oh, good, very good question. Actually, I still say a living donor is the best. You know, unfortunately, when we have a deceased donor, even a younger donor, first of all, you ship the kidney from one place to another on ice. Second, the circumstances, you know, surrounding death, especially if the donor died from a stroke and such, we know that this can induce certain chemicals we call them cytokines and such in the deceased donor, and that can influence the quality of the kidney when it's being transplanted. So I would say always the living donor wins. Now, if it's extreme age, if the donor is 70 and you have a younger deceased donor who's 20, probably the deceased donor of 20 is better. But if they're close in age or a little bit, 10 years difference or 15 years difference, I would say a living donor always wins.
Okay, this is related. Are there different degrees of matching for living donors versus deceased donors?
Yes, that's a good question, actually. Yeah. Yes. When we have a living donor, we have the time to do the matching. We actually look at more antigens, including something called DP antigen that's not yet included, I think, in the deceased donor allocation. They said it will be included soon, but I don't think so far it is. Yeah, we do further testing to rule out donor-specific antibodies at the time of transplant or before transplant. It's more exhaustive in living donor than the deceased donor. Yes, it's better actually because we have time and we do more subtyping of the antigens.
Okay. Is there a national living donation matching program, so similar to UNOS for deceased donation?
You mean someone who doesn't have a living donor and just get matched with a living donor?
Yes.
Someone who doesn't have his own or her own living donor and they get entered into matching to get a living donor? I don't understand the question.
I'm not sure if it's that or just so if you have a living donor but they're not a match for you, is that a national program like the paired exchange? Is that a national program?
Well, if you have to have a living donor directed to you, unless the transplant center direct non-directed donor, altruistic donor to you. You always need to have a living donor yourself. There's no program in the country that assign living donors who volunteers to give to a stranger to recipients. Now, yes, if a recipient has a living donor who is not compatible, there are national programs, one administered by UNOS, and another one really successful is called the National Kidney Registry, where we can list actually the incompatible recipient and donor to get actually to get into the exchange program. Yes, there is a national. There are a couple. Actually, there are more than 2 national registries or programs that match donor and recipient through paired exchange. There is the UNOS one. There is the National Kidney Foundation, and there is the Alliance for Paired Kidney Donation out of Toledo, Ohio. Here at Mayo, we collaborate with the National Kidney Registry, which is the most active one nationwide. Other questions?
I think that got to the bottom of that question there. Thank you. Are there any nutritional needs for living donors, like low salt, low fat diets?
Typically, we don't restrict, but we ask people to follow a healthy diet. If they donate or they don't donate. It's actually a recommendation for everyone to follow that healthy diet. Post-donation, yes. This is why they meet the dietitian to go over what they eat and give them, some counseling about healthy options. It's not a requirement. Donors can do whatever they like, but it's actually a recommendation to follow a healthy diet. And we caution people, about weight gain. As we age, we all tend to gain weight, and weight gain and obesity is the main risk factor for kidney disease down the road, because it increases the risk of diabetes and high blood pressure. So we give them a lot of counseling, a lot of education materials about healthy living, and if they ever donate a kidney, how to avoid gaining weight and such, but it's not a requirement to follow any diet per se.
Okay, thank you.
Any other questions?
Yeah, we have a lot of questions, and I'm going to kind of move away, I think, from living donors just a little bit. Alexis told me that you guys are all still there, so I really appreciate you taking all these questions. If you're listed at multiple centers, do you need to go through all of the tests at all of the centers, or can some of those tests be shared?
Yes, you need to. This can have some financial, concerns, because yes, any given center cannot list anyone without physically evaluating the recipient. So we counsel patients when they come that they are free to double, triple list, do as many as listing as they want in the country in different regions, but they have to have the financial means to travel to those centers. Now, some centers may accept certain testing that was done at another center, so they may do a mini evaluation or more focused evaluation and accept whatever is done in another center, but they have to be physically, it's a requirement actually, this is a regulation that they meet with the team in any particular center. Yes, they have to be physically evaluated by any respective center they get listed in.
Okay, thank you. So we're going to switch gears a little bit again. Does having had multiple pregnancies affect being matched for a kidney donor, or a donor kidney, I'm sorry?
No, having previous pregnancies, actually, it's not, does not matter. Actually, we prefer females of childbearing age to have their pregnancies done before donation, because there is some evidence in the literature that post-donation there is some increased risk of having something called preeclampsia. Post-donation is very small risk, is not actually a high risk. So we prefer people actually of female at the childbearing age to have their family and have their kids before consideration of living kidney donation. However, if they want still to plan a family, they can actually get pregnant after donation. We typically tell them wait about a year, at least 6 months to a year before getting pregnant. But I think better if they have already their family and they planned it, so they don't have to deal with issues, even a small risk post-donation.
Thank you.
Other questions?
What is HLA?
Okay, HLA, it stands for human leukocyte antigen. So just to make it easy for everyone, all our cells are actually fingerprinted by HLA. That's a human leukocyte antigen, so it's particular to the human species. Now, animals have also their own antigens that are expressed on their organs. This is why we cannot actually have, we cannot cross species in terms of transplantation, something called xenotransplantation. So the HLA, it's actually a fingerprint of our cells, and the kidney cells express the HLA. This is why people who develop antibodies prior to transplant, they may have directed donor-specific antibodies against those fingerprints on the cells, and they can reject them. So it stands for human leukocyte antigens. To give you an idea how, when they determine paternity, they test actually the DNA for those HLA. That's actually because this is a fingerprint that we inherit from both our parents. So, other questions?
Yeah, we'll do one more question and then we can move into the next session. I believe, Dr. Issa, in your presentation earlier, you mentioned the mortality rate for dialysis patients. Is that due over a 5-year period, I believe? Is that due to complications or due to personal decisions to discontinue dialysis?
Oh, that's due actually to medical complication. Typically, dialysis patients unfortunately die from cardiac-related problems, calcification of their coronary arteries. Now, I should caution you guys, you know, the audience is PKD patients. PKD patients are a little bit different, and they're actually, I would say, maybe different than the average dialysis patient in this country. You know, the main cause for kidney disease in this country is diabetes. And most of those patients who die actually once the dialysis starts are those who come to dialysis with a package of a lot of cardiac disease and stuff. So this is actually an overall mortality because it includes people at higher risk. It includes diabetics and everyone who, any incident patient to dialysis. But PKD patients, thanks God, they do actually well because most of them are healthy. They only have the cysts that actually take over their kidneys, and they're usually very healthy people. And actually for us, when we transplant polycystic kidney disease, we have the least concerns in terms when we evaluate patients polycystic kidney disease. But the mortality actually does not differentiate who has polycystic kidney disease, who has diabetes, or other types of kidney disease. So that mortality is general, but includes mostly high-risk patients. So a polycystic kidney disease patient may actually survive longer on dialysis, if I would say. Yes, the prognosis is somber for dialysis patients because, as I said, it includes higher risk patients.
Okay, thank you.